Hello and welcome to Lecture 5 of the Clinical Anatomy Programme's Medical Embryology module. In this video we will be looking at the screening and diagnostic tests available in the UK for pregnant people, for spotting congenital malformations and the chromosomal abnormalities. After this video and any further necessary study, you should be able to explain the difference between prenatal screening and diagnosis, give an account of prenatal screening procedures in the UK, describe the methods of prenatal screening including maternal serum screening and ultrasound, describe the diagnostic tests and discuss the risks and benefits of each, discuss the emerging techniques of non-invasive prenatal screening and diagnosis and their benefits and wider implications, discuss the use of pre-implantation genetic diagnosis in IVF, and be able to apply this knowledge to case scenarios. So all the screening and diagnostic tests that we will be looking at today will require an accurate dating of the pregnancy to take place first. This is because some of the screening options are only valid within a certain window of development, and outside that window of development those screening techniques are not reliable enough to give an indication of whether there is likely to be an abnormal development. Additionally, for some of the diagnostic tests, it's actually dangerous to perform these outside of the allotted time frame, as they could be detrimental to the developing fetus and trigger spontaneous abortion or prenatal death. As clinicians, your primary role of determining gestational age will be to ask the pregnant person for the date of their last menstrual cycle. That is, the date of their first day of their last period. This is a non-invasive way of approximating fetal age as it requires the answering of a question. But the problem with that is it is not very accurate. When we consider the very small window of time it takes for all of the systems to develop, the approximate age based on the menstrual cycle can mean there are huge windows of missed opportunity. And given the risks associated with some of these diagnostic tests, an approximation may exacerbate these risks. If you consider females that have irregular periods due to PCOS, they may not have menstruated for 6 months but potentially might only be a few weeks pregnant by the time that you see them in clinic. Additionally, those pregnant people that were on birth control when they conceived might also have an additional obstacle in their accuracy of dating a pregnancy. Finally, it's also not unusual to continue to bleed in a false menses whilst pregnant. All of these things can make dating a pregnancy by the acquired date of their last period almost null and void, however convenient it is to ask. One way to skirt around this is to perform an ultrasound scan to estimate fetal age. This first routine fetal scan is offered to pregnant people around 12 weeks after the expected conception date, but it might be necessary to get a scan sooner if they are unsure of the date of conception, or if there have been any history of pregnancy complications. Before we can talk about screening or diagnostic tests, it is important to confirm the terminology that we will be referring to throughout this lecture. Screening tests look for an indication that something might be abnormal. They are not a definitive diagnosis, and they have a variable accuracy rate. A screening test will not be able to confirm that there is an issue, but provide a series of positive or negative indications of whether there is likely to be an issue or a complication throughout the pregnancy. Screening tests run alongside gestational age in ultrasounds to ensure that we are within the window of accuracy. They are acquired through maternal blood analysis, drawn venously, and markers within that blood are measured. They look for a specific set of factors secreted by the fetus or placenta that diffuse into the maternal circulation. And if these markers are within the normal range, it is indication that the pregnancy is likely to continue as normal. When these factors fall outside the range of normal, it suggests that there may be an abnormality that requires the use of diagnostic tests to confirm or deny whether there is a specific abnormality present within that fetus. Diagnostic tests are the only tests that can confirm whether a specific order or malformation is present in the fetus, and they are normally more invasive and come with potential risks, but we will look into these more specifically in a few moments. So why screen? Well, we want to determine the health of the unborn fetus. Many of these screening tests are able to provide more information than an ultrasound alone. The information from the collection of tests can give an indication of the likelihood of a problem. The results of the screening test can help provide parents with an informed choice about whether to look for more invasive diagnostic tests, or whether they need to consider the overall outcome of the pregnancy. The screening tests provide the medical team with the opportunity to put plans in place in a high-risk pregnancy or delivery. Do they need to have the NICU team on standby? Do they need to deliver by C-section? Additionally, screening might reveal conditions that might affect future pregnancies, and so provide parents with the information to decide whether it's safe for future pregnancies, or whether future pregnancies may cause devastating decisions to be made. Given that approximately 1/5 of perinatal deaths are attributed to congenital abnormalities, screening may offer parents the opportunity to terminate the pregnancy preterm to prevent the excess physical strain on the pregnant person carrying an unviable fetus to term, reducing the risk of an unnecessary surgery in the attempts to deliver a baby having undergone prenatal death. In the UK, all pregnant people are offered screening tests for Down syndrome. It is important to remember that these tests are screening tests and can neither confirm whether the fetus does not have Down syndrome. They suggest the likelihood of the fetus having Down syndrome. There are currently 2 Down syndrome screening tests, and depending on the age of the gestation of the pregnancy, determines which of these tests are available. Both of these tests can only be conducted with an accurate dating ultrasound scan. The first test is the combined test, and this requires the fetus to be between 11 and 14 weeks, or 45 to 84 millimeters long from crown to rump. On the day of the dating scan, if between this time window, venous blood is drawn from the pregnant person and analysed for serum markers, human chorionic gonadotrophin, pregnancy-associated plasma protein. During the dating scan, if consented to do so, the ultrasonographer will measure a pouch of fluid of the dorsal region of the neck. This is called the nuchal translucency. The combined results from this NT measurement and the serum markers are then input into a computer-generated algorithm, and a risk factor is calculated. This risk factor is delivered to the obstetrician or midwife and the pregnant person. If the risk factor is believed to be greater than 1 in 150 chance of having a fetus with Down syndrome, then diagnostic tests are offered to the parent. Another screening test offered to the pregnant person is the quadruple test. This is most accurate when undertaken between 15 and 18 weeks, but potentially it can be undertaken as far along as 22 weeks of gestational age. The serum test uses maternal venous blood sampling and quantifies the alpha-fetoprotein, the unconjugated estrogen called estriol, HCG, and a final marker called inhibin A. Collectively, these numbers are analysed alongside the maternal age, because we know that there are increased risks of chromosomal abnormalities with increased maternal age. Although the only thing we are specifically screening for and calculating the risk factors of the fetus is having Down syndrome, but these tests can give an indication of whether there are other chromosomal or congenital malformations present, which could help to determine the likelihood of needing a diagnostic test. All the pregnant people in the UK are also offered a second ultrasound regardless of the results of the Down syndrome screening tests. This is the fetal anomaly scan, which takes place approximately 20 weeks into the gestational period and screens for other congenital malformations. So, as already mentioned, the only screening offered routinely are to screen for Down syndrome, but the results from the combined and the quadruple test indicate whether there are other abnormalities present. The combined test, for instance, can suggest whether it is likely that a trisomy 18 is present. The pregnancy-associated plasma protein A is found to be below normal range in both Down syndrome and Edwards syndrome. But in Down syndrome, the HCG levels are above normal range, and in Edwards syndrome, the HCG is below normal range. This information is combined with a nuchal translucency measurement to indicate the likelihood of either of these trisomies being present. This allows for early indication as the pregnancy is between 11 and 14 weeks, but the detection rate isn't that accurate, hovering at around 80%, and the risk of false positives is quite high at 5%. In simplest terms, 5% of the positive screening tests generated are not as the result of the fetus having either of these trisomy abnormalities, which potentially could raise ethical concerns for the undue stress put on the parents to decide whether to opt for a risky diagnosis test or whether to terminate a pregnancy. The quadruple test, the fetus has a neural tube disorder and below the normal range in the case of trisomy 21 and 18 pregnancies. Unconjugated estrogen is also below the normal range in these latter two pregnancies. We have already seen in the combined test that HCG is elevated in pregnancies carrying a fetus with Down syndrome and below normal range in pregnancies carrying a fetus with Edwards syndrome. But we have also found that inhibin A is elevated in the case of a Down syndrome fetus. It is worth reiterating that both the combined and the quadruple tests must take place between their allotted gestational time frame, and so they must have been conducted having had a dated ultrasound scan, in conjunction with the serum blood draw. So the reason that we use ultrasonography is because it's safe, cheap, and the image quality is very good, and we are seeing regular improvement with this technology. The first measurements taken during an ultrasound scan are to determine age. The primary measurement for this is the crown rump length, which measures the most cranial aspect of the head through the middle of the fetus to the most caudal region of the trunk, aka the derriere. This is the most accurate measurement for determining gestational age and can be used independently, fairly accurately, if the fetus is not cooperating for all the measurements required. The second most accurate way to measure the femur length is to measure the femur length of the fetus, and the third most accurate way is to measure the biparietal diameter of the skull. In reality, when the fetus cooperates, all three measurements are taken and input into the computer of the ultrasound machine, which then calculates the gestational age in weeks and days, allowing for an estimated due date to also be calculated. Sometimes, as mentioned, the fetus not appears to cooperate, although obviously not intentionally, and it can be difficult to acquire all of these measurements. So priority is given to the crown rump length, if this is able to be obtained. There could be other difficulties associated with the accuracy of measurement due to fetal positioning, maternal habitus, i.e. whether the pregnant person's BMI is hindering the quality of the image, or whether the uterus is easy to view. The combined test usually runs at the same time as the gestational age scan and requires the scanning of the nuchal translucency to be viewed. This is the thickness of the pouch at the posterior aspect of the neck. The normal limit is 3 mm for a 14-week-old fetus and 2.5 mm for an 11-week-old fetus. The degree of thickness is directly proportional to the risk of a trisomy present, with an NT thickness of 3.5 at 14 weeks, meaning that there are a 20% risk of a trisomy fetus, and 8.5 mm thickness, indicating a risk of 75% of a trisomy fetus. In the event these screening tests indicate a high-risk pregnancy, i.e. a pregnancy with more than 1 in 150%, with more than 1 in 150 chance of a fetus with Down syndrome or any of the other trisomies or congenital malformations picked up by the quadruple or combined test, those parents are offered a diagnostic scan to rule in or out a confirmed congenital malformation. These tests, commonly offered in the UK, are the chronic villus sampling and an amniocentesis. Occasionally, and depending on the postcode lottery, Pregnant people over the age of 35 may be offered a diagnostic test routinely because of the increased risk of a baby with a chromosomal abnormality, correlating with the maternal age at the time of conception. They may also be offered routinely if the parents have already had one child with a congenital abnormality, or if one parent is known to have a chromosomal abnormality. So let's have a look at the diagnostic tests available. Chorionic villus sampling is where a small sample of placenta is moved either transcervically or transabdominally, both with ultrasound guidance. Unlike the screening tests that can be obtained by the ultrasonographer and a phlebotomist or midwife, the chorionic villus sampling must be performed by a doctor, usually an obstetrician. It can only be performed between weeks 10 and 12 post-conception. Diagnostic tests like the chorionic villus sampling are able to determine the karyotype of the fetus, as the placenta is constructed from those trophoblasts during implantation. Those trophoblasts are derived from embryoblasts and therefore contain the same DNA as that of the fetus. Those chorionic villi are then analysed after culturing and can reveal chromosomal, genetic and molecular abnormalities. Now, the chorionic villus sampling does come with some risks, which is why alternative diagnostic tests are usually favourable, and why chorionic villus sampling isn't as widely used as tests such as the amniocentesis. The risk of miscarriage is between 1 and 2%, but the data is a little sketchy. In more recent years, research has suggested that maybe the miscarriages didn't happen as a direct result of the test. The nature of these diagnostic tests is because the pregnancy has been determined as high risk, which could account for a fairly high miscarriage rate rather than because of the procedure itself. There is also a risk of amniotic leakage, leading to something called oligohydramnios, infection, and fetal injury. Additionally, we could experience a false positive because of mosaicism. So the cells analysed are placental cells, and it is possible that those placental cells are not identical to the fetal cells. When looking back at the pathways that allow for mosaicism, placental tissue may be subject to mosaicism, where the fetal cells that have come from a separate cell lineage, and so the chorionic villus sampling may give a positive result for an aneuploidy fetus, but the fetus itself may actually be euploidy. An amniocentesis is a sampling of amniotic fluid. This cannot be performed before 15 weeks because the removal of fluid large enough to sample at this time will leave too little fluid behind for the fetus. It is normally performed between the weeks 15 and 16 to diagnose chromosomal anomalies, but it can be performed at any time after 15 weeks until delivery. Amniocentesis involves the ultrasound guidance of a transabdominal withdrawal of amniotic fluid. Within that fluid are cells of the fetus. These cells come from the sloughing off of fetal skin in utero and from the lung and the urinary tract. Whilst in utero, the fetus practices breathing by inhaling the fluid and exhaling it out. As it does, sloughed off lung tissue ends up in the amniotic fluid. We can then use this for genetic, chromosomal and molecular analysis to search for anomalies. Additionally, if performed in late pregnancy, the lung tissues can give an indication of lung surfactants present in the fetus, which are directly correlated with the fetal chance of survival in the event of a preterm delivery. This might be particularly beneficial for people experiencing eclampsia and requiring a preterm birth. There are risks with amniocentesis, which is why the skill of the practitioner is particularly important. The fetus, depending on the age of the pregnancy, may be quite large, so the risks of fetal injury might be significant and will change depending on the age of gestation. Ultrasound guidance is required, which aims to reduce the risk of injury. There is also a risk of amniotic leakage, a risk of rhesus sensitization between the pregnant person and the fetus, and therefore we give a RH prophylaxis and prior to the diagnostic test. The risk of pregnancy loss is lower than chorionic villus sampling at 0.5 to 1%. However, the data does not make it clear whether these pregnancy losses were as a result of termination after the results of the amniocentesis. The actual statistics of pregnancy loss is thought to be about 0.06%. If performed before 14 weeks, this jumps to as high as 7%. The cells from an amniocentesis of or chorionic villus sampling are karyotyped and can reveal aneuploidies, microdeletions, duplications, and translocations. In order to perform these tests, cells must be cultured for 2 to 3 days and are then arrested in metaphase by culture scene. The nuclear membranes are ruptured with the use of a hypertonic solution, and then the loose DNA is stained with Geismar. And a photo is taken with a light microscope to reveal this. So once we have a picture, the chromosomes are arranged in order of size and paired together as appropriate, leaving the sex chromosomes until the end. The Geismar reveals a selection of dark and light bands, revealing the heterochromatin and euchromatin that have few and many genes respectively. This can then be compared to determine if there are any anomalies present. There is an alternative to traditional karyotyping called fluorescence in situ hybridization, or FISH. For FISH to work, PCR must clone selections of DNA and produce a series of probes. A fluorescent marker or antibody binds to this sequence of DNA under investigation when reintroduced to the sample, and it localizes the fluorescence when viewed. FISH has its limitations because we have to know the sequence of DNA that we are looking for, but this allows us to bind specifically and search for microdeletions. As technologies have evolved and ARTs have evolved, it is now possible to test for genetic chromosomal anomalies in vitro. This is offered to parents who carry a known genetic or chromosomal abnormality. During the first few days post-conception, whilst the zygote is undergoing cleavage, a single blastomere is removed from the ball of cells and examined by FISH. As these cells are still totipotent, the remaining cells will compensate for this removed one, and therefore there is no harm to an embryo that develops with this missing embryoblast. FISH will be able to highlight whether it is suitable or viable to use this pre-embryonic stage morula. But as you can imagine, there are ethical considerations to be aware of. And naturally, news like this breakthrough makes its way into the media and can cause anger amongst some groups that suggest this technology might be misused or abused. In 1997, scientists discovered the DNA of a fetus had made its way into maternal circulation. As the cytotrophoblast apoptose, fetal DNA breaks away from the placenta and makes its way as cell-free DNA into the maternal circulation. This cell-free DNA chains are visible in the maternal circulation from as early as 4 to 5 weeks and have been seen to increase over the duration of the pregnancy to where they may be as much as 50% cell-free DNA belonging to the fetus making its way around the pregnant person. Although this information is not new news, having been identified nearly 30 years ago, testing this cell-free DNA is not as simple as drawing maternal venous blood, and this is because that cell-free DNA is very unstable. However, after advancements, these tests are available privately, so it is hoped that eventually they will be available on the NHS. These non-invasive prenatal tests are highly accurate when screening for most of the common trisomies, but are less accurate for Turner syndrome, and they are only screening and not diagnostic, so a traditional, more invasive diagnostic test will still be required to confirm diagnosis. There are some non-invasive diagnostic tests available in the UK, and these can test for some of these congenital defects and disorders. But it might be a case that traditional diagnostic tests are required to confirm, either way, whether there is a congenital or chromosomal anomaly present. So a side-by-side comparison for screening for Down syndrome. The combined tests will indicate the likelihood of carrying a fetus with Down syndrome. 95% of these pregnancies are considered low risk. That means there is less than a 1 in 150 chance that the baby will be born with Down syndrome. Of these 5% higher risk, they will be offered a traditional or conventional diagnostic test, whether that is chorionic villus sampling or an amniocentesis. Side by side, these non-invasive pre-diagnostic tests we can see take place earlier in pregnancy, having been able to take place from approximately 10 weeks. They are more accurate, with a 98% accuracy rate at spotting Down syndrome. There are also fewer false positives, but in order to get a diagnosis confirmed, conventional diagnostic tests may still be required. Here we have a case study. This is one of 3. Read the text and then pause the video and work your way through. Clinical case study 2. And case study 3. Now, we mentioned right at the beginning that all UK pregnant people are offered Down syndrome screening tests in the first trimester. This is followed up by a fetal anomaly scan at 20 weeks, where a longer and more thorough ultrasound is taken to determine the likelihood of other congenital malformations. The list below are what are specifically screened for, but they are not exhaustive of the things that can possibly be screened for. The National Screening Committee dictates the congenital malformations that should be screened for, and although there are other disorders that might be picked up during an ultrasound scan, the detection rate is quite low, so these are not offered routinely. The measurements are taken by the ultrasonographer and combined with further maternal serum markers such as AFP, HCG and E3. And a risk factor is produced which will help clinicians determine the appropriate clinical pathway and further diagnostic tests to determine whether a diagnosis is or can be made. For further reading on this subject, please view the papers and links below. You should now feel more confident in undertaking the self-directed learning aspect of the module to ensure that you could complete these learning objectives.